We're really excited this year because of the growth in the number of attendees. We grew about a third compared to last year. The faculty and attendees represent 31 countries. So we're really excited about the interest that venous disease is finally receiving. It was the orphan vascular field for a long time. Yeah. So that's the first thing we're really excited about. The second thing, in terms of the three major developments, I'll let John elaborate on this, but I believe post-attract refinements of science in that front is probably the next most exciting thing here, right?
Yeah, and I'll just add also 10 specialties at the meeting. Yes. So there's just broad interest, which gives you a sense of how compelling this field is and how important it is and how it cuts across all different kind of specialties and backgrounds. I think with the ATTRACT, the subset analyses have been very interesting and gratifying to those of us who had felt that there is something there. And when the original publication came out, hard to sort out who's going to benefit. The subset analyses showing that those with primarily iliofemoral disease, and separating out from the infrainguinal only, and the benefits that they see in terms of the severity of their post-thrombotic syndrome with early intervention has been very interesting. It's what we're going through is a process of refining the indications, understanding who's going to benefit most from the intervention. So we're getting way beyond just the technique. We've got a technique, we want to apply it broadly, getting much more into the pathophysiology, the long-term outcomes of all these disease processes. And that was a theme throughout all of the talks.
So I believe, we starting from stripping to when radiofrequency was first approved by the FDA in 1999. We have laser, then we had non-thermals. There are now new biologics, all sorts of different technologies are coming in to ultimately eliminate that venous reflux. And in the deep system, below the infrainguinal, below the inguinal ligament is what I'm talking about. Vein valves was also a new thing now. So I think ultimately, like Dr. Kaufman said, it's appropriate patient selection and having a proper strategy and plan for the patient to ultimately feel better. All these technologies, in my mind, are just tools in the toolbox, and you pick the right one for your patient.
There are actually, for superficial disease, so many options at this point. It can be looked at as just an incredibly rich field for research to really understand the long-term outcomes, the biology of what's happening to these veins. We have a lot of theories, but we're getting to the point where people are really interested in understanding what actually is happening to the vein when you treat it with these different modalities. And I agree with you, the deep system, we've been dancing around this for decades, trying to understand how to intervene in the deep system successfully. There have been a lot of interventions proposed. Venous valves are beginning, percutaneous venous valves are beginning to come back again, and there seems to be some interest. So there may be, in the next meeting, who knows what we'll be hearing about.
The important thing as we build upon the ATTRACT data is to minimize those bleeding risks and improving the clot extraction. And, keep it simple and short, I think, is the key.
Yeah, I think it's been very interesting, the reflection back on the cost of these interventions. Yeah. And when you have a 3-day intervention, there's a different cost than if you can do it in one setting. And yet there may be some other downsides to trying to get it done all at once rather than extending it. So just a lot to learn, and continued stimulation for new devices and new approaches. As with the superficial world, I don't think we know their answer yet as to what is the best. And again, no one presented any technology as being the ultimate. It will likely be the right technology for the right patient in the right setting.
As a vascular physician, if I am, sending a patient to the cath lab for, an intervention, I want to make sure that the patient doesn't have complications. Right? That's the first part. And the second part is, like, John mentioned, healthcare dollars and, value-based medicine is going to be very important in the United States. And as we brace ourselves, in terms of new technologies, thrombectomy devices are probably, I wouldn't say game changers, but are they? Would you call them game changers?
Yeah, I think there is such a challenge. I mean, they potentially could, and in theory, the idea that you could go in and just scoop everything out or suck everything out and just be done is a very attractive concept. Yeah. But this is where I was referring to a combination of tools, that there may be, for every patient, we may not have just one solution. We may need to combine tools. And in some patients, because of the age of the thrombus, how their anatomy, their clinical circumstances, you may want to lean more towards an infusion therapy as opposed to a extraction therapy. But good thrombectomy devices that reliably and quickly remove large volumes of thrombus without a lot of other kind of issues to worry about with the patients are going to be very compelling as we gain more experience with them and learn how to use them. So I think one of the really interesting phenomenons in this space, not just at this meeting, is the explosion in the venous stenting. Now that we have dedicated venous stents, the threshold and into stent is maybe a little lower, and the interest is a lot higher. I think my guess is that people didn't anticipate the appetite for these stents that has been experienced in clinical application, and yet there's so much to learn about the stents. These are really the first generation venous stents. How to manage them over the long term to prevent restenosis is going to be critical. What the viability of these devices over 40, 50, 60 years, which in some cases will be their dwell time in patients. We just have a lot to learn. But I'm not interested in your take on this, just how much of this is suddenly happening, and as opposed to before, it was a little trickier to get the stents just right.
You're absolutely right. I think, the first generation stents now that are on label have challenged the next generation of stents that are coming in, even though they're IDE trials. Right. They want to differentiate themselves. They want to make it better than the previous one. So ultimately, that kind of push to have that incremental improvement every time a new stent is, coming to the market is ultimately going to benefit patients.